One of the topics that we haven't had time to talk about together in a while is antivirals. And, you know, I remember we had conversations even a couple weeks ago when you had some skepticism about the idea of this malaria pill effectively and mixing it either with zinc or with Z-Pak or things like that. I'm curious if your view has changed at all on that, only because you continue to hear anecdotal evidence that when people get on it early enough after being tested, and of course tests are so important in all of this, that at least with mild cases, it has had success. Is that right or wrong?
Well, look, the data is still early. There was another study out of China with about 60 patients that showed some effect as well. These are small studies, and we need to properly study it. The drug's been effective in vitro in test tubes, but it's shown activity in vitro against other viruses where when you put it into humans, it didn't have activity. So I think we need to study this drug. It might be weakly beneficial. It might be providing a treatment effect, but we don't know. Remember, this is being widely used right now. Doctors are using this both in the United States and outside the U.S., and doctors are also in Italy taking it prophylactically, from what I hear, to try to prevent infection. So if it's having a treatment effect, we're not seeing a very robust treatment effect. Now, to your point, you might have to use these drugs earlier. Two of the other drugs that are pretty far along right now in clinical studies are remdesivir by Gilead, which acts directly on viral replication, and Avigan by Fuji, which is another drug that's been approved in Japan, stockpiled in Japan for flu, that also acts directly on aspects of how the virus replicates. These are in later stage studies, and data should be coming out on both of them within the next month or two. That's going to turn over a card to tell us whether or not these might be working. So these drugs are now available. They're being made available on a compassionate use basis, but none of them have the kind of definitive data that you'd want to really conclude that they're having a robust treatment effect.
Right. And Doctor, we're hearing that the White House is going to be releasing some of the models that they've been looking at and using to make policy and thinking about policy decisions. Do you have any idea about what their models may look like that differ from some of the models that maybe the public is looking at now?
Well, one of the models that they've been looking at is a model out of University of Washington, this IHME model. I tweeted it out yesterday so people could see it. I know that a lot of folks in the White House have been looking at that model, and that model has been similar to what the administration has been modeling, what CDC has been modeling and putting forward. I think one of the revealing things for folks inside the government right now is that when you look at Hong Kong and Singapore, their economies have largely restarted. The consumers have come back. They're in restaurants. They're going out. They're wearing masks. They're taking caution. Life isn't exactly what it used to be, but they've come back. In China, the consumer has not come back. Factories have restarted. Government-run factories and other factories have restarted, but consumers are still scared to go out. And so I think what that tells you is you really need to definitively defeat this virus to bring the consumer back. Now, China, which is a manufacturing economy, can probably sustain itself with their consumers being out of the economy to some degree. But the U.S., which is a consumer-led economy, really needs to make sure that the consumer comes back. And so I think what that says to policymakers is we need to defeat this virus. We need to get over this. And people need to feel confident that we have the tools in place to now make sure this doesn't happen again so people can go back to living their lives. Because if this becomes a pervasive threat here in the United States and the consumers are reluctant to go out, reluctant to shop, go to restaurants, go to theaters, that's going to be a big protracted drag on the economy.
Hey, Scott, the latest on Europe, I'd like you to comment on whether there's a slowing in the increase. I guess it's a second derivative. I don't know. We may be looking at third derivatives. Comment on that. Comment on whether New York, when you listen to Governor Cuomo, who talks about a slowdown and how quickly things are doubling, patients at hospitals, and he looks at that as a positive. And then third, so I don't have to keep trying to with these delays, do you think that the ventilator situation in New York City at this point has caught up with where we're going to be in a week or 2 weeks?
Right. Well, there's some indication at least peaking. They've been sort of peaking for a number of days now. The cases kind of level off, come down a little bit. You have a day that spikes, comes back down. I think that that's the case. I think Italy's starting to peak. Germany's been doing a good job keeping up. Spain's still rising up their curve. In New York, I think there's a likelihood that they're going to peak in 7 to 10 days, which is consistent with what the governor said a week ago. And when you look at their data, there is some indication in their data that things are starting to improve. Now, they're still going to have new cases. It's still going to grow, but the rate of growth has been slowing a little bit. And remember, hospitalizations and ICU admissions and tragically deaths as well are going to lag the growth in cases because there's a delay between time to hospitalization and also time to death. I think the governor's been doing a very good job in that state, leading that state. I'm proud to have been a New Yorker and have worked in those hospitals when my colleagues are still working very hard for many years. I think the ventilator situation in this country is going to be really pressed. And the question is, can you move around equipment? It's going to be very hard to do that. And I think the states that, like Florida, Louisiana, Florida is likely to have a very big outbreak, and on a per capita basis can be one of the hardest hit states. I mean, they're racing against the weather. Hopefully, as the weather warms there, it's going to be a backstop. But they didn't act early, and they have a lot of infections, and it looks like they were seeded very early. And I think the feds are going to be tapped out. Their ability to backstop some of these other cities and states the way they did New York is going to be limited, and you're not going to be able to move those resources around so quickly. So communities around the country, cities, need to be thinking about how do you shut down elective surgeries in community hospitals, preserve PPE, move ventilators and equipment and providers into the urban settings like New York did. I mean, Cuomo really sort of, he looked at the state as one hospital system and started to move resources out of the community hospitals that weren't going to see cases and move them into urban centers that were, and move the cases into those urban centers. So they kind of corralled all the resources in the hotspots. Other states need to be thinking about that holistically statewide.
Hey, Scott, I have a related question. I know in Wuhan, part of the reason they were so successful is they were able to bring in doctors and equipment from all around China and make sure they hit that problem hard. Here in New York, you have Governor Cuomo asking for help from other states and other localities. But what are the odds that that happens when so many of these other states are facing their own potential outbreaks in the near horizon?
Yeah, that's the challenge, Becky. It has happened. Some doctors from out of state have moved into New York, and I'm hopeful that doctors from New York are going to move out of state, especially the ones who've learned how to treat COVID patients effectively as they see their epidemic come down and other parts of the country heat up. But remember, according to the data that China put out, and I know it's the data that China puts out, you have to take it with some caution, but they had no province that had above 1,500 cases. We must have probably 17 states right now with more than 1,500 cases. So we're going to be dealing with multiple hotspots, and some of those are going to be quite large. You look at states like Michigan, you look at states like Louisiana, you look at states like Florida, Texas. Texas is going to have a bigger problem than what the data is reporting right now. Even Massachusetts, Boston, Illinois, these states are going to have a lot of cases, and those cases are going to build. And we're not going to be able to shift around providers and resources the way China was able to, both because we don't have the same top-down command and control that they did, but we're also going to be strapped nationally.
You keep listing all of these places that are going to have problems. Where in the United States are there not going to be problems?
Well, look, I think that there's parts of the country that feel unaffected right now. If you look at hospital census data in the Midwest, it's very low. Parts of rural America haven't seen the virus come to their locations. This is going to start in urban centers, and hopefully it ends in urban centers because we come up against the summer. This epidemic runs its course. The mitigation steps that we're doing have their effect, and we're able to preserve life and contain this. But any place can be affected. I live in a small town in Connecticut. We have probably 100 cases here from a single introduction that we were able to trace it back to. So any place can have an outbreak. Any place can have infection. So everyone's going to be vulnerable. Germ theory tells us this could spread across the whole United States if we let it. This is a virus that wants to infect about 40% of the population. Now, we're not going to let that happen. But if we let this go, it could, and any place can be host to it.
Doctor, I just wanted to talk again about the timeline, though, because as you mentioned, new cities, states, municipalities where you think a hotspot, it could emerge if it hasn't emerged already. Each of those hotspots are going to come with their own curve. And to the degree that this is still a free country and people are going to travel, we don't know how much they're going to travel, the potential for reinfection is real. So in terms of, you've talked on our program about mid-May, maybe some parts of the world going back to some semblance of normal, or early June. But when you start to talk about some of these other places that don't seem that hard hit yet, and you start to say to yourself, okay, well, is that an 8-week to 10-week process in there? And then you keep adding them along. It seems like this could stretch out longer. Am I wrong?
Well, the mitigation steps are going to actually stretch it out longer, and that's the point of putting in place mitigation. You kind of push down the peak of the epidemic, but stretch it out. But I think the rest of the country is largely on the same curve, which puts it like 2 or 3 weeks behind New York, probably more like 2 weeks. And so you're going to see the rest of the country light up at about the same time. There'll be some parts that maybe lag by a week. But, you know, there is some precedent for, as this sort of progresses into the summer, it becomes epidemic in the United States, the epidemic runs its course, and it kind of collapses as you get into July and August. And so that's what happened in 2009 with H1N1. Coronas typically don't circulate in the summer. So the summer should be some element of a backstop. Now, given the fact that this is so novel, we have no cross-immunity, it's going to still transfer between people in warm months where otherwise a coronavirus wouldn't. But we should have some natural backstop as we get into the really hot, humid months. And so this could just run its course and start to collapse as it warms. But I think that we're likely to see the peak based on the models we're looking at sometime in late April or early May. And then we have to wait a couple of weeks before we start contemplating slowly withdrawing these mitigation steps. So April's going to be a difficult month being in our homes. May is going to be a month of transition. As we get into June, we're going to start coming back again. And then in July and August, we should be, you know, coming back to some element of our normal lives with a lot of new introductions of features to try to prevent this from happening again. And then hopefully when we come back in September and this virus wants to come back from other parts of the world where it will be spreading, we have a much different toolbox. And I think we will. I think we'll be much better prepared in September. But we need to start thinking about that now because, you know, we didn't take certain steps in January to prepare ourselves for March. We need to start preparing in March and April for August and September.